Good, and welcome to today's virtual nonpartisan briefing. I'm Alyson Northrup, a senior policy officer at the Robert Wood Johnson Foundation. We're a leading national philanthropy dedicated to taking bold leaps to transform health in our lifetime and paving the way together to a future where health is no longer a privilege, but a right. For 52 years, RWJF has been a trusted nonpartisan source of information on policy and programs to improve health and well-being in the United States. Today, we'll be discussing the state of healthcare affordability in the United States and strategies that policymakers can consider to make healthcare affordable for everyone in the US. The focus of today's briefing will not be to discuss specific legislation or legislative strategies, but rather to provide information about the issues and opportunities more broadly. I'm looking forward to the conversation. Before we dive in, a few programming notes for us. We will have plenty of time for Q&A, so feel free to share your questions in the chat throughout the discussion. A recording of today's discussion will be shared with you in a follow-up email, along with the resources referenced during today's discussion. And near the end of our time, we'll share a link to a brief survey in the chat. We appreciate you completing it. And lastly, before we begin, I wanted to make sure that attendees of today's briefing are aware of a resource supported by the Robert Wood Johnson Foundation called the Congressional District Health Dashboard. This is a first-of-its-kind tool that tracks data on health and its drivers by congressional district. This was launched in partnership with the NYU Grossman School of Medicine, and the tool provides actionable nonpartisan data on 37 measures of health and its drivers in all 435 congressional districts and the District of Columbia. It enables users to explore what's happening nationally, at a state level, and by congressional district on specific measures of health and well-being. And relevant to today's discussion, as part of the most recent data update to the dashboard earlier this spring, the dashboard now includes data on Medicaid enrollment by congressional district. You can visit congressionaldistricthealthdashboard.org to explore the tool and find data specific to your communities. And with that, I'd like to introduce you to our expert, my colleague and friend, Kathy Hempstead. Kathy is a senior policy advisor at the Robert Wood Johnson Foundation. She works on healthcare issues and mostly those related to health insurance, healthcare costs, and access to care. In her work, she seeks to inform policy discussions at the federal and state level by making data and analyses widely available. She frequently offers expert insights, you may have seen her quoted in your favorite publication, that make complex healthcare topics more approachable and understandable for everyday audiences. She is considered one of the nation's leading experts on health policy, and I'm excited to have her with us for today's conversation. Kathy, thanks for joining us today. Yeah, sure. So I'm inviting you into the conversation now. I want to start with a bit of a stage setting question to begin the conversation. So could you start us off by briefly discussing at a high level, what are some of the current trends in healthcare affordability in the US today?
Sure. Yeah, I'm really looking forward to this conversation as well. I'm hoping that we can keep it really conversational and sort of high level and talk about a range of affordability issues that I think policymakers are thinking about, and end with some things that really make a difference to consumers. So maybe if you want to go to the next slide, I can provide a little context to talk about what Alyson was asking. And this is one of my favorite healthcare quotes. Healthcare is the tapeworm of the US economy by Warren Buffett. And I think we're all familiar with the kind of long-term, multiple decade narrative about problems with the affordability of healthcare in the US. And when we, for example, compare ourselves to peer nations, we know that healthcare costs are higher in ways that don't seem related to quality. Outcomes in the US are often poorer, and many people lack coverage. And when we think about sort of trends in the cost of healthcare compared to other goods, we know that healthcare costs have risen more steeply, which is what you can see in this graph. And that means for people that, for example, receive insurance through their job, which is the case for the majority of working age adults, It reduces the growth in their real earnings, leaving less money for savings and other things. And that's why Warren Buffett calls it a tapeworm, something that sort of consumes an ever-growing share of our national product without actually adding any increased value. And that's why for for consumers, voters, healthcare is an enduring pain point, and a lot of people lack access to affordable coverage. Although we've made some progress on that issue in recent years, for sure, but for millions more that have coverage, people struggle to pay premiums. They have trouble meeting their responsibilities under their deductible, their copay, their co-insurance, and hospital bills and the cost of prescription drugs are really challenging for people. And people in general, when they're polled, have a really dim view of major participants in our healthcare system, like prescription, pharmaceutical companies, insurance companies, and providers, and are looking to policymakers to do things to make healthcare more affordable. So that's sort of, I think, like a little bit of a table setting. Does that make sense, Alyson?
Absolutely. So I feel like you've laid out the problem for us a bit. We've heard about rising costs in healthcare and what that means for actual people and their ability to save and do the things that they need to do to live healthy lives. So I'm curious if you could take us. You pointed to people turning to their policymakers for solutions to healthcare affordability. What are some of the tools that are available to policymakers to help bring down the costs of healthcare in the U.S.?
Sure thing. Yeah. So we could go to the next slide, if it's okay. And and again, like I kind of teed up at the beginning, affordability can mean a lot of different things. And one of the sort of things that we think about are what kinds of policies can make healthcare more affordable at kind of an aggregate level, or affect the sort of amount that our society spends on healthcare. And there are a bunch of strategies there that I'm going to talk about for a while. But then I think we also need to think about, well, what are things that we can do, that policymakers can do to make healthcare more affordable for individuals? And it's not always the same thing. There's some things that affect both, but sometimes there's really a trade-off between, what makes things more affordable at the aggregate level and what's more impactful for individuals. But going back to the kind of the issue about like the cost problem with American healthcare, when people say, well, why what is going on in the US? Why is healthcare so expensive? Why is it so more expensive than other places? Again, like going back for a second to kind of the comparative context, when we compare the US system to peer nations, the thing that we find most consistently is not so much that we're using more care than other nations, but that we're paying more for it. So, a lot of research, some of which we've funded and, many of which has been funded elsewhere over the last couple of decades, have sort of led us to realize that it's, as was famously said once, it's the price is stupid. It's the prices that we pay for healthcare that really differentiates the US from our peer nations. And so a lot of the policy activity around affordability is thinking about what can we do to affect the prices. And on the sort of healthcare services side, which is a big bucket, there's been a real awareness in recent decades, especially maybe the last 15 or 20 years, about the rise in the ratio of commercial to public prices for inpatient and outpatient care. So that's the ratio of sort of the commercial to the Medicare rate. And that's something that's been increasingly well documented in different kinds of reports. A really famous example, I think, and a really important example is the report that the Rand Institute puts out. And this year's report just came out last week, I happened to notice, which showed that once again, there's about a 250% of the Medicare rate. The ratio is about 250%, the commercial to the Medicare price for the prices that employers are basically paying for care. And when we think about why that's happening, we tend to, and if you talk to different people, you'll get some different answers. But I think a lot of the consensus comes down to the fact that a lot of our healthcare markets are not really working as well as they should, for reasons that often focus on consolidation and things that interfere with competition. So there's a lot of policy activity, and I'm sure, many people listening today are aware of different efforts that are trying to make our healthcare markets more competitive and make them function better. And, some of them are to require more data about prices that payers are paying providers, so that there can, be better awareness of prices and hopefully reduce variation in prices that have little to do with quality, and sort of get closer to to prices maybe closer to Medicare rates. And there's been a lot of effort to calculate what hospital break-even rates are and what sort of ratio of Medicare is really appropriate. And there's a lot of evidence that consolidation in provider systems has resulted in higher prices, and there's been a pretty robust research literature on that. Another sort of aspect of this is to be more kind of energetic around antitrust, both at the federal and sometimes the state level. There's more interest in having more oversight of healthcare transactions to, this is something I think a lot of states are getting more interested in particular, to see, what kinds of acquisitions are taking place, and who's purchasing healthcare entities. Competition policy is important too. There are certain anti-competitive aspects to the way providers and payers interact that allows people to exploit market power. And so there are increasingly efforts to try to make the competitive nature of our markets function better. Price regulation is something that also can be relevant, especially when there is a sense that competition is not really working well. So there's obviously in the IRA we've seen some provisions to negotiate with pharmaceutical companies in the Medicare program, and there's some state policies that are taking some steps to try to think about making some requirements around provider prices in certain markets. Many decades ago, many states tried to regulate hospital prices with sort of mixed success. But there's a portfolio of strategies out there that are trying to reduce the cost of healthcare services, reduce the cost of prescription drugs by combinations of trying to make the market function better from a competitive standpoint, but also, sometimes talking about different kinds of regulation.
Great. Thank you so much, Kathy. So was there something else you wanted to add? You sounded like you had another thought at the tip of your tongue.
Well, there are a million examples. The No Surprises Act is another one that tries to kind of regulate the way a price is established in a certain context to reduce, reduce out of network billing to consumers, but also to not just push that cost completely back into the premium, but to also try to create some, some parameters around what that negotiated price can be. And, that's obviously anyone who's been following some of what's happening with that knows that it's, that it's not easy. So, I think I wanted to kind of just sort of signal that there's a strategy of really important policies that people are pursuing at the federal and the state level to try to address healthcare costs kind of at the price level, sort of at the source. And those kinds of measures will, be very, very important to make a difference in kind of how sort of the tapeworm problem and how much of our GDP goes to healthcare. But I'm getting ready to kind of like pivot to another way of thinking about affordability. So maybe we could go to the next slide. And this is I think this is a really good thing for people to look at. This is the Milliman Medical Index, and it shows the kind of retail cost of employer coverage for four. And, 2023, it was $31,000. Median income for a family of four is like, something like $80,000 around there. So you can see that that's a very, very, large share of the average person's income, and that would be very, very difficult for people to pay for. So I'm using this to kind of help us pivot to thinking a little bit about how we think about affordability kind of in an individual context, because all these sort of more upstream affordability policies are super, super important. But I think it's not that hard to see that even if you could imagine, repricing all of healthcare in terms of Medicare prices, or making a lot of other really significant strides in reducing the price of healthcare, you would still see that for a lot of people, getting health insurance would be a huge affordability challenge. And that's why, many people, really almost everybody gets some kind of subsidy for their health insurance. And that's sort of what we're going to talk about now, are some of the things that can help make coverage more affordable for people. So, people that get their insurance from their employer, they are sharing the cost with the employer, though arguably they're really, that's all sort of part of their compensation, but there is a big tax incentive. But, nevertheless, many people find what they need to pay is very difficult for them to pay. And then their cost sharing is difficult. And employers have had to sort of push more and more of that expense onto enrollees through deductibles and high cost sharing. So,
Kathy, just really quickly, this sticker price that we're looking at, 2023, the 31,000, that would be paid by both. That would be the employer and the employee contribution.
Yes.
Right. That amount isn't okay. Thank you.
Yes. And it's a kind of an eye-popping number, and it does go up every year. So yeah, that's a good clarification. And I show it in part to show that, healthcare, we can do a lot of things upstream, and healthcare is still going to be unaffordable for a lot of people. So now, I think it is, so it's good to remember that policymakers need to be thinking about sort of both aspects of affordability, and think about the sort of aggregate aspects and then the sort of individual aspects. And, you can even think about it that sometimes there's some trade-offs, and there's some trade-offs that are worth making, like expanding coverage obviously is, an incredible improvement in affordability for the people that get coverage, but it also increases our aggregate expenditure on healthcare. Now, I think, that's a good trade-off for people to make, but there's often sort of a trade-off between, what's affordable for society, what's affordable for individuals. So now, talking a little bit about making things more affordable for individuals, because if we can't do that, we sort of haven't accomplished anything. So at the end of the day, this is really something that policymakers need to think about very much, too.
Yeah. So what are some of those ways that we can make coverage more affordable for individuals?
Sure. Well, we have, with employer-sponsored insurance, we have, obviously there are some tax subsidies that make that more affordable for people. Medicare is something that's become a little bit more affordable with recent reforms, but that's obviously, heavily subsidized, and, between beneficiaries and taxpayers. We have Medicaid, and then we have the individual market, which is something that really fills a gap that we had before the ACA, which was people that didn't qualify for Medicaid, weren't old enough for Medicare, didn't get coverage from their employer, really didn't have an affordable option. So we now have a new kind of subsidized individual market that has been growing a lot in recent years, particularly because we've seen an increase in affordability as a result of the tax credits in the individual market. So I think we could go to the next slide now. Excellent. And now we're going to talk about sort of some of the, some of the issues in rural America, which we decided to use just as kind of an example of a place where all of the problems that we have with affordability of healthcare in America are kind of triangulated. Like, so, for example, rural populations are older. They tend to have poorer health. They have lower income, more likely to be uninsured. And we also see problems kind of on the supply side, because we see that healthcare markets are less competitive. They're more expensive, so healthcare actually costs more. And then a lot of times there are sort of scale issues that, make things worse and reflect the fact that population is declining in some rural areas. And we have provider shortages, and we have, sometimes hospital closures, which is a problem that we're not going to talk about today, but it's a very, very serious problem.
So all of these factors seem to be coming together to make healthcare affordability in rural communities just a massive issue.
Yeah. I mean, I think it's also worth mentioning, of course, there are, many other sort of elements of, disparity in healthcare affordability. There's a huge racial element, and, we see that populations of color are more likely to lack coverage. They're more likely to have issues with medical debt. They're more likely to have trouble with, high deductible employer plans. So the rural differentiation is a really important one, but there are, many aspects of sort of the disparate effects of affordability problems in the United States that, reflect and in many ways exacerbate sort of underlying inequality that we already have.
Yes.
I wanted to focus the most recent analysis that we did on the rural context, because we were particularly interested in looking at farm states, and one of the reasons that I wanted to take a look at farm states is because farmers are a really important occupational group. They're not a huge occupational group, but they're obviously critically important because they produce food, which we definitely needs. And, it's a high risk occupation. Farmers need to have a lot of different kind of insurance. And traditionally getting health insurance has been a real problem for farmers because they tend to fall into that category before the ACA, where they would have to go out into the individual market and try to get coverage. And a lot of times that coverage was, sort of, not necessarily comprehensive. You could be underwritten if you had a medical problem, and lose your coverage or not get your coverage. And so it was a problem. And in many farm families, one person would have to have a non-farm job just to get the benefits, and that would interfere with the sort of growth of the farming business. So it was interesting, a question that I think everybody was sort of interested in looking at, to see, now that the ACA has been in place and we have these enhanced premium tax credits, we have the expansion of Medicaid, and not all, but the many leading farm states, how important are these sources of affordable coverage to people in these leading farm states? And the way we defined these farm states is by looking, and there's a lot of ways to think about this, but we decided to look at states where farm operators were the sort of 10 leading states where farm operators as a share of the labor force. So those are the states that we focused on. You can go to the next slide now, if that's okay. Yeah, and here they are. And we actually have, in the brief, we have congressional district level data on this, but for this, so we don't like blind people, we just show kind of at the state level. But we actually use that NYU resource that Alyson talked about to pull together. But we wanted to see how important are these sources of coverage to folks in farm states. And we looked at both Medicaid and the individual market. And you have to look at this as a little crude because it's just a sort of a per capita measure. And, theoretically you would maybe exclude the 65 plus population. So it's a little bit of a low ball estimate, if anything. But you can see that in these states, these two forms of public coverage are super important. Looking, with going from, Kentucky almost, Kentucky is the highest. I'm sorry, my eyes aren't as good as they should be, down to South Dakota. But even in South Dakota, we see almost 1 in 5 people enrolled in either the marketplace or Medicaid. And just like it has in other parts of the country, marketplace enrollment has grown a lot in these states over the last few years as coverage has gotten more affordable. So I think that was, definitely something that we wanted to put across and let people know about, and also to let people know that we have this, great congressional district level data on Medicaid enrollment, and we also used congressional district data on marketplace enrollment that CMS released for the healthcare.gov states that covers most of these states. So I think,
Yeah,
what do you think, Alyson? Is that good?
that,
You
I
want to
mean,
go to the next?
yeah, so just I wanted to refer people to the chat because Kathy mentioned that this was a recent analysis, looking at these 10 leading farm states and looking at affordability and enrollment in, public health programs, Medicaid and marketplace programs. So the link to that brief with those congressional district level numbers is in the chat. And that this brief will also be included in the follow-up that we send after today's briefing. But yes, we can move on to the next slide.
Yeah. And I would just say, I really would encourage people to look at the congressional district level data if they're interested in those states, because, I think there's some, pretty surprising numbers in there. And it's just, I think, good to get that level of disaggregation out there when, when it's available for important things. Okay. Yes. Thank you.
Yeah. So you mentioned the advanced premium tax credits as part of this, analysis of rural states. I'm wondering if we could just take a few minutes to talk about what that policy is and the role that the advanced premium tax credit, which folks may or may not be familiar with, what role that tax credit plays in healthcare affordability.
Right. Yes, absolutely. So thinking just about that Milliman medical index, you don't have to go back to it, but just kind of thinking about that bar chart, seeing kind of that's sort of the sticker price of health insurance and how expensive it is. And, everyone that really has health insurance has some kind of, some kind of way that the cost of it is partially subsidized by government. And so we talked about the employer context. There's a big tax incentive and there's a little bit of a share with your employer. Obviously Medicaid is for very low income people. Medicare, there's sort of sharing between taxpayers and the beneficiary. And the individual market has a set of tax tax credits that are based on income that, offset the cost of the premiums. There's another set of subsidies that affects cost sharing called cost sharing reductions. And, we don't really need to talk about that right now, but it's also designed to have people, to keep people from sort of facing the retail cost of healthcare. Because if, the other thing that the ACA did was it required that these markets, provide very comprehensive coverage and not refuse to cover people that have pre-existing conditions. So they basically made them comparable to employer coverage. And so if you have those requirements, the policies are going to be expensive. And if you don't subsidize them, literally nobody would be able to afford them. And so it would, it wouldn't be a helpful market. So there's this, very important aspect of these markets is that there are these tax credits. And, people felt like a limitation of those tax credits was that the subsidies ended when people reached 400% of poverty. So people that reached 400% of poverty actually then sort of were facing that kind of sticker price that we talked about before. And not surprisingly, enrollment was very, very low, for people in that income range. And, people also felt like the subsidies, weren't as generous as people really needed them to be at lower income levels, and, there's no sort of right answer for, what the right level of generosity is, but the enhancement of the APTCs, which happened over the past few years and was then, extended with the IRA, increased the size of the subsidies and also removed that subsidy cliff so that people at 400% of poverty were not excluded from getting subsidies. And, since that's been in place, we've seen a very large increase in enrollment in the marketplace. And, it seems like it would be particularly important in places like some rural states where we might have, more people like farmers who may have faced the subsidy cliff before because their income was a little bit higher, and also because many farmers are a little bit older, so they would have higher premiums, and also because premiums are higher in some of those states in particular, because the cost of healthcare is greater. So I mean, these enhanced APTCs are important throughout the country. Of course, they're super important, and they've really contributed to increased enrollment. But we were especially interested to see, what share of people in these farm states are using APTCs, and what kind of a difference are we seeing in sort of average premium? How much are they reducing premiums? So I
That's
think
great.
you could go to. Does that sound good, Allison? Did that answer your question?
Yeah, well, just what I heard is that the enhancements were important both for people at the lower end of the income scale and for people who are at that 400,000, 400% of poverty level, which never means something in my mind. So can you just say like an annual salary for a family of four,
Oh my
400%?
gosh, I was afraid you would ask me that.
No,
I always.
so I won't test you. I Googled it because I never know offhand. And it's about 120 to
Oh, good.
125,000 a
Okay.
year for a family of four would be
Right.
that 400%. So those are kind of the ranges that we're talking about where this policy makes a difference.
Yes. Yeah. I mean, it makes a big difference. A lot of people are now eligible for policies with zero premiums at the lower end of the income scale, and then it opens the door really for people above 400. So it's really been transformative, and it's been associated with a great acceleration in enrollment. So it's also really contributed to the stability of the market by bringing in healthier risks, probably. So that's that's an important aspect too. So it's it's been it's been really helpful for the growth of the market. So, and if you want to go to the next slide, which I believe is the last slide, we can see the difference between these two bars is large, right? And it shows the difference in the average premium for, with and without the tax credit. 90% of enrollees use the tax credit in these farm states. That's true across the country. It's not really any different in the farm states in terms of how many people use them. But, Wyoming is the third most expensive state in the country. After Alaska and West Virginia. And so you can see in a state like Wyoming, the advanced premium tax credits make a really, really big difference.
Yeah, certainly.
Yeah. So, I mean, I think I feel like we've kind of traveled around the world of healthcare affordability here in
Just a
35
taste.
minutes.
Yeah.
Yeah, talking about like a million different things. But I mean, I think the bottom line is, it's all important. The upstream stuff about transparency or site neutral or, the No Surprises Act and antitrust and all the things that policymakers are working really hard on to try to reduce the prices of healthcare are tremendously important, and we need to keep doing them. But at the same time, for many people, coverage is going to remain unaffordable because it just still is going to cost too much compared to people's income. So making sure that everyone has access to a source of affordable coverage is critical as well. And that's another important component of affordability. And the creation of a subsidized individual market has filled a very, very important gap in our system, which is admittedly deeply flawed, fragmented, crazy patchwork system that nobody would invent or choose, but it's what we have right now. Yep. And juicing up those tax credits has made a huge difference in enrollment in the risk pool. And so I think you can really see the impact in a state that has a lot of health problems and an important self-employed occupation, farming, that has a need for coverage. And I think that's what I've got for you today, Allison.
Well, I got to ask you my questions, but now we get to give an opportunity to our audience to ask you some questions, and they've been coming in furiously and folks can continue to submit questions. But I am going to kick us off with the first question. Someone actually submitted in advance, which is always awesome, and means we're likely able to get to you. So the first question from the audience is, what opportunities exist for partnerships between federal policymakers and leaders and their counterparts at the state level related to affordability?
Well, I think the one, I mean, that's a great question. And I always admire people that submit questions before webinars, which for some reason I never can, I don't have the presence of mind to do that. So kudos to you for doing that. I mean, I think that, you know, you can say for better or worse, a lot of our federal programs are, you know, our health insurance programs are federal state partnerships, like, you know, Medicaid, the ACA, aspects of the ACA. But I think in terms of, you know, the thing that came to my mind immediately was the CMMI model that is rolling out and is going to involve states. And it's really a model that is exploring sort of new ways of pricing sort of global budgets for hospitals. It's called the AHEAD model. And so that's a very clear example of a way that, you know, federal and state policymakers can collaborate in a kind of, you know, like a demonstration of different ways to think about pricing hospital care. So that's one example.
That's great. And maybe we have a friendly person who can pull that that model for us. You said AHEAD?
I think it's AHEAD, yeah.
Okay, CMMI model. In the meantime, I will bring us to our next question, which was also submitted in advance.
But I just want to say, I mean, I think that states are doing a lot of really exciting stuff around affordability. This just, you know, which I think, you know, the federal government, I'm sure, is watching, and there may be some ways to learn. A lot of states are engaged in these kind of benchmarking efforts where they're putting sort of soft pressure on market participants to, you know, to slow the growth of healthcare spending through setting a target and trying to identify, you know, whether the target's being met, and if not, why not? And these things are not easy. I think they're being facilitated by the fact that there's much better data now on prices, you know, coming from things like the RAND report, which, you know, we are very proud to have funded. And, you know, since then, the required transparency reporting by payers and providers, which I do have confidence will become more usable. And maybe someday we'll also have a national APCD. We'll see, but there are better sources of data. And I think that can help state regulators to sort of see, you know, what seems reasonable, who's an outlier, what can be explained, what can't. So I think states are doing some really exciting things. And, you know, California, for example, has started a real affordability effort where they're even, you know, thinking about putting some, you know, some kind of mandatory caps on growth. So there are different ways that states are looking at this. And, you know, states in some ways have some tools that feds don't, because they regulate their hospitals and they can do certain things. So I think there are a lot of interesting activities in the affordability space going on in states. Sorry, go ahead.
No worries. But can you did mention all payer something?
Yep. Yeah, all payer claims databases. That is exactly what it sounds like. It's a database of, you know, it excludes people that don't have insurance, but it's all claims. So, you know, in a perfect world, it's all the employer claims. You know, and a claim is like a, you know, a description of a service and a bill for payment, and see what the payment is. And, you know, that is a really important data source that can let people sort of understand what's being paid for care and, you know, differences and trends. Some states have these, some states don't. A lot of people, you know, myself included, think a national all-payer claims database would be a really great resource to sort of drive affordability efforts. And, you know, there's certainly a lot of interest in that, you know, and I think states that have APCDs have made a lot of great use of them. You know, they're also good for other kinds of research too, to look at differences in care that different kinds of people, they're not just about prices, but they're really helpful for affordability kinds of projects.
Yeah,
and
for healthcare policy nerds like yourself, it would be a dream.
Well, myself and others, and we have sponsored access to lots of state APCDs to do different research projects under the Health Data for Action authorization. So it is something that we've been really behind. And, you know, maybe someday there'll be a national APCD, and that would be a great thing.
I do want to try and squeeze in a
Sure.
couple more questions. What are the most successful affordability strategies to address equity in communities?
Well, I mean, definitely things that make coverage affordable for people. I think we have a lot of racial differences in affordability, access to affordable care that relates to the failure, for example, of some states to expand Medicaid, which puts disproportionately populations of color in the coverage gap. So I think the single policy that would make the biggest difference in increasing sort of equity of affordability would be to close the coverage gap. And, going from there, it would be measures that make coverage affordable. And that includes, expanding Medicaid, having the APTCs, reducing cost sharing, So I think it's thinking about the individual rather than these upstream factors, which are also super important, but
Yep.
different.
Okay. So we have time for just one more. This is our final audience question from Kenneth, and he asks, how do value-based models impact healthcare costs, including health insurance premiums?
Oh, that's a really hard question.
Thanks,
And
Kenneth.
I don't, there's not an, I think, I don't think the jury's in on that yet, believe it or not, as long as we've been sort of talking about it. I mean, there's a whole school of thought that, that says value-based payment would save a lot of money because it would incentivize providers to, to keep people out of the hospital and to follow up and to do this or that, and we'll pay people for value, not for volume. And there's, that makes a ton of sense. Has it translated into, a lot of slowing in healthcare cost growth? It's not clear yet, but it's certainly not clear that it hasn't, and I think that that's an opportunity for, for research. It's very difficult because sometimes the models, the sort of things about the models leach into sort of the control group, and then it seems like there's no effect, and maybe there really is an effect. I mean, I think there's every reason to think that would make a difference. On the other hand, I think there does then tend to sometimes be pushback from people if they feel like maybe they're not getting, they're getting prior auth on things that they think that they should be getting. So there's always a little bit of a push and pull around managed care. I mean, from a logical basis, value-based care makes a lot of sense. So I think, and I think it's progressing, certainly, we're all under some kind of managed care arrangement. And I don't think we have quite figured out what the sweet spot is yet. So that's a very ambivalent answer, but it's a really important question. And then that's why
something to
CMMI is so
continue.
important.
Yeah.
For setting up these really important demonstrations in, different kinds of value-based models.
So something to continue to monitor, certainly.
Definitely.
We are, believe it or not, coming to the close of our session. So first, I want to extend a huge thank you to Kathy for sharing her insights and her brilliance with all of us. I get to do that all the time, and I'm glad to be able to share Kathy with all of you today. I want to thank all of you for participating in the discussion. We appreciate your time and interest. We know time is such a precious commodity, especially in your roles. We have put a link in the chat for a brief anonymous survey. We appreciate you completing it. It helps us to plan future events and really target them to your needs. We'll provide a recording of this webinar and a link to the survey as a follow-up to today's session. Thank you all so much, and I wish you a great rest of your day.